Okay, it looks like the participant counter has slowed down. So we will get started here. And I believe more people will be joining us as the morning and the day go on. So welcome. Again, I am Cynthia Bauer, Director of the Horowitz Center for Health Literacy at the University of Maryland School of Public Health. And I'm here with our co-convener, Michael Villaire, Executive Director for the Institute for Healthcare Advancement. Michael, would you like to say hello?
Sure. Hi, everybody. Thanks so much for joining us. This is our, as you can see from the slide, our fourth annual Health Literacy and Action Conference. This is one where we try to combine the elements of policy and practice so that people can get a good understanding of how to use some best practices, some strategies, some great ideas to advance health literacy practice and health literacy policy. And we appreciate all of you being here. So, Cynthia.
Great. Well, first, of course, to acknowledge that no conference happens without a lot of staff making it happen. So Michael and I want to acknowledge the staff, both of the Center for Health Literacy and the Institute for Healthcare Advancement, who have been working diligently over the last several months to put this program together and to make the technology work. So thank you to all of our staff for doing that and making this possible today and getting the website up and all of you registered. So just acknowledging all the hard work that goes into that. As Michael said, this is a conference where we focus on practice and policy, really evidence into practice, right? So the things that you're going to be hearing about today really reflect the evolving scientific basis as well as the best practice basis for a lot that's going on in the health literacy field. As Michael noted, also, this is our fourth conference. Hopefully we'll be back in person with you all very soon. We're looking forward to that. But in the meantime, we invite you to enjoy the program over the next day and a half. And just want to, all of our programs are dynamic. I highly recommend all of them. I do want to do a special shout out for our closing keynote. We're very excited to have Professor Kathleen Hall-Jamieson, one of the most distinguished political communication scholars in the field, and she will be doing our closing keynote tomorrow afternoon, and you don't want to miss that. But again, I highly recommend all of our sessions to you. Michael, you have a few housekeeping details you'd like to share with everyone?
Yes, thanks. Anna, can you advance to that slide? So if you are having any technical difficulties, please go back to the conference homepage, and there is a link for the virtual help desk. For your continuing education credits, you do need to submit an overall conference evaluation in order to receive your certificates. So the links to that evaluation will be sent to you sometime within an hour or so after the conference concludes on Friday. This presentation is being recorded, and it'll be posted on the Health Literacy Solutions Center, which is healthliteracysolutions.org, 2 weeks after the conference. All of you will be muted during the presentation, and there will be a Q&A session at the end of the presentation. If you have questions, we just ask you to go ahead and type those in the Q&A box found at the bottom right of your screen. There's a chat box, so if you want to just sort of informally chat, feel free to use that. For an actual question for any of the presenters or the moderator, please use that Q&A button. All right. Cynthia, anything else you want to touch on before we go ahead and jump into the program?
No, let's get this curtain up.
Great. So thanks again, everybody, for being here. I'd like to introduce our opening speaker, Mr. Dewan Patterson. Among many reasons why we asked Dewan to be here, he wrote a blog, which is published on our Health Literacy Solutions Center, again, healthliteracysolutions.org. And he has a very powerful and resonant message about using credible messengers, which he'll talk to you about in just a moment. But Dewan is an advocate, a public servant, and a social media impact consultant with the Bridge Advisory Group. As a Baltimore native, he's developed a passion for the prevention of gun violence, addressing societal inequities and community empowerment. He received his bachelor's degree in psychology and his master's of public administration and public policy from Bowie State University. Mr. Patterson leverages unique personal and professional background as a grassroots leader in community and government affairs to be well positioned as the nexus between the community, government, non-government organizations, and businesses. And now I'll go ahead and turn it over to Dewan. Thank you very much.
Thank you for that. Good evening, everyone. It's relatively different for us to continue to be here about 16 months later, to be doing everything virtual. I'm a person who really enjoy and feeds off of energy. So it's unfortunate I can't see some of you beautiful faces, but we're here. So once again, my name is Dewan Patterson. I'm presenting on the credible messenger approach to public health crisis. Next slide, please. So many people may ask, what exactly is a credible messenger? A credible messenger is a trusted neighborhood leader, experienced community advocate with relevant life experience. Many people may see there are self-appointed people who represent folks just because they resemble a community. But if you don't have relevant life experiences related to a given policy or issue, then you can't really consider yourself as a credible messenger. Some of the attributes of a credible messenger is having an established credibility with relevant life experiences, beliefs, and values. So if you have a person who have experience with heart disease, asthma, some certain types of cancer, then they could be a relevant, credible messenger for that given issue. A proven track record of protecting the community interest. This is something that's really important because it speaks to the level of credibility of that messenger. Because many people may be self-appointed, they may see themselves as a representation. However, they're not really credible within the community. The next piece is demonstrated ability to deliver mutual beneficial outcomes for community members. If you cannot deliver results that's mutually beneficial, not only to the institutional partners in which you collaborating with, but those community residents is really important because they see these things, and this is how you become even more trusted and credible inside community. Lastly, it said maintain accessibility and proximity to the community. We all can hear and witness during COVID-19 when we wanted to promote residents and citizens to get the vaccine. And you notice that there are people who taking the vaccine on social media and doing PSAs. However, we still see a real sharp increase of vaccine hesitation. And that's because they're not people who are credible in close proximity to the individuals in which you want to influence. I give you an example of a credible messenger, which is here, a person that's local in Baltimore is Troy Staten, More Than a Barbershop Initiative. He has partnered with healthcare practitioners and the University of Maryland to bring about awareness on COVID-19 vaccines and different information to get out there right there. Troy Staten is a non-traditional type of leader, but there's a barbershop owner and a barber who have constant relationships, interactions with community members, so they trust them to deliver valuable information. Next slide, please. And I'll speak up really quickly on my role as a credible messenger. Given the understanding of COVID-19 last year into now, I had the privilege to actually work on a project with the FDA and the University of Maryland on the communication about COVID-19 testing among underrepresented population. And throughout my partnership, we noticed that since I had a constant relationship with my institutional partners, I was able to keep them informed of what was happening to me and my community. We noticed that my family, through multiple generations, was drastically impacted by COVID-19, from my grandmother all the way down to her granddaughter, which is my niece, from Maryland all the way down to South Carolina, all been impacted by COVID-19. Why is this important? Because as I maintain my communications with Dr. Mullins at the University of Maryland School of Pharmacy, it was a privilege to actually be able to inform research ideas and design and topics as it relates to my community. And you see that level of alignment that was happening. You see that alignment happen so we could design certain research topics, emerging trends. And since I had a strong credibility representation, that assists me to be able to recruit people in some of the most difficult to reach and strong hesitant population. So that was a lot of people who use social media to get a lot of their trusted information and bringing them inside the research to really share their attitudes, beliefs, and values as it relates to COVID-19 testing. Accessibility. Since I was actually in close proximity, not only physical, but psychological, being able to translate the information was really important when it came to not only recruitment, but retention. When we had the focus groups, there were some times where participants did not see the value in the research or the questions. So being able to translate the information was very valuable. Whether it's from the institutional side and say, hey, we may need to translate, reformat, reframe the questions as we engage people, because everybody do not have the same type of health literacy or awareness across the board. Next point was the trust maintenance. Trust maintenance is really important being a credible messenger because your reputation is on the line. People see you as a trusted source, similar to a peer review. If you look at Yelp and you see there are individuals who will vouch or discredit a given establishment, similar to a credible messenger. They will co-sign an institution or a project and gives a level of validity that you can continue to be a part with this project and this institution, and they value you as a partner. Dissemination. Dissemination was really critical. Oftentimes, dissemination is low on the totem pole of priorities because we already secured funding, we already implemented the research, but we forget that there's a certain level of give back that's necessary to avoid the mentality of helicopter research. You extract and you send out of the community. Dissemination is really important. So I help to translate the information to give back to the community so they can maintain this level of engagement and a sense of making deposits as well as doing withdrawals. Next slide. The benefits of a partnership with a credible messenger. The community benefit side of it is a greater deal of trust between the residents and community leaders within that community academic partnership. And so you can see some of the other benefits that's actually on the slide. I will not read it verbatim to you. But once you have greater sense of trust, you now increase your ability to retain authentic communication and information gathering. Relevant results and information is really critical when it comes down to research. It will improve the efficiency as well as the results in which you're gathering. And also it enhances your reputation, your image. We all have heard of institutional mistrust due to some of the historical injustice that happened as a result of research, Henrietta Lacks. Here in Baltimore, there's also another one that's not as talked about as Henrietta Lacks, is the Kennedy Krieger study with asbestos and lead paint removal inside communities. So these are the type of things that's really important when we're talking about using the credible message that they help you to build trust, credibility, and deliver results that make a positive impact. And it also improve institutional service delivery and community participation, which are things that's really important to help you meet your objectives, and the community have a level of respect for you because you understand there's cultural differences and values in which you govern based on who you select as a credible messenger. Next slide, please. My call of action. We have to promote and invest in more credible messages instead of appointing spokesperson. And when I refer to spokesperson people, these are people who just look like the community in which you're trying to engage, but they're not of the community. So we have to make sure that they are aligned in values, experience, proximity, and credibility when you select incredible messengers. Next thing, establish more bi-directional learning with communities, especially communities of color. When we talk about learning, you need to be a student as well as a teacher, because we can all grow and learn from each other. Make intentional investments and actions to promote collaboration of credible messengers. One thing I always ask my institutional partners and participants when I'm giving keynote address or opening statements, ask yourself this reflectional question: how are you advancing your community partnerships, or what are the type of investments to grow partnerships in that capacity? So I will actually leave that task with you to reflect on: how do you make investment on partnership growth between community and academic partners? My name is DeJuan Patterson, and I'm a social impact consultant with the Bridge Advisory Group. And I thank you for opening up this conference today.
Thank you so much, DeJuan. I was part of the team that DeJuan just described. And, you know, I really felt like his contribution, the contribution of a few other credible messengers in the team was just, you know, the project couldn't have happened without them. So thank you so much for sharing that experience and giving us that call to action, because I think your call to action is spot on for this group. They are definitely a group that can respond to that call to action. So I think you are being a credible messenger with the right group. So thank you so much for taking some time out of your day to share that message.
Thank you.
Okay. So again, I'm Cynthia Bauer. I'm director of the Horowitz Center for Health Literacy at the University of Maryland School of Public Health, co-convener of this conference along with the Institute for Healthcare Advancement. And I'm here to kick off our opening session of our day-and-a-half conference. So welcome to everyone. Hope you are comfortable, have a cool or warm beverage to drink, whatever your preference, because we're going to get started with our first session here, which is taking a look at a very important new initiative from the federal government, from the Federal Office of Minority Health, which is part of the U.S. Department of Health and Human Services. So I'm joined today by three speakers who represent three of the funded activities under this new funding opportunity announcement. I've seen in the chat that a few other people who also received this grant are in the meeting today, so that's really great. We're excited to have more grantees here. We're going to ask each of our speakers to give us no more than a 10-minute overview of their project, and then we will have an open Q&A with them. So I think we should have plenty of time before we wrap up at noon today. My job, in addition to moderating, is just orienting you all to what the funding opportunity announcement was, just so you know what the grants are about and have some context for the different projects that will be described. Next slide. So as I said, this funding opportunity announcement, or FOA, came from the Federal Office of Minority Health, and it was called Advancing Health Literacy to Enhance Equitable Community Responses to COVID-19. So its focus was, as the title says, to improve health literacy related to COVID-19 specifically, but as we will see, it really has a longer term agenda to focus on some organizational health literacy changes that can happen within the course of the project. The focus is on racial and ethnic minority populations and those with social vulnerabilities as defined by the CDC Social Vulnerability Index. Each project has to develop what's called a disparity impact statement. And within that statement, they have to be very specific in identifying the populations and the social vulnerabilities experienced by those populations. And then each team has to develop a health literacy plan, an evaluation plan, and a work plan. And those are the guiding documents for their projects. Next slide. In terms of who could apply for this announcement, it was local municipalities, which would mean a county or city government. So those are going to be the leads on all the projects. And from what I've seen, they typically have many, many partners or stakeholders who are part of those teams. The Office of Minority Health asked for each team to include minority serving academic institutions to provide the quality improvement and evaluation components. The projects began as of July 1st this year and run for 2 years, so until June 2023. And there was a total of $250 million in this particular announcement. Rural communities could apply for a maximum of 3 million and urban communities a maximum of 4 million. Next slide. Personally, I was very gratified to see that the funding opportunity announcement, as well as the directions that have come from the Office of Minority Health since then, they use a lot of the health literacy tools that many of us have been part of developing over the years. So there's a requirement to use the National Action Plan to improve health literacy, the Healthy People objectives, the class standards, class standing for culturally and linguistically appropriate services, and then the new Healthy People 2030 definitions for personal and organizational health literacy. There are many other tools that people can choose from, but these are the core ones that everyone needs to reference in their health literacy and evaluation plans and work plans. Next slide. So our first speaker today to talk about their project is one that I'm also personally involved with. The Horowitz Center is a partner in this particular project. And our first speaker is Elizabeth Chung, who is Executive Director of the Asian American Center of Frederick in Frederick, Maryland. And for the sake of time, I will refer you all to the conference site for people's full biographies. Each of our speakers has a very long and illustrious career, but we know that you really want to hear about their project, so we're going to get to that. So Elizabeth, please share with us what Lifting All Voices is working on.
Thank you very much, Dr. Bowers. Is my mic on, first of all?
Yes, it is. We can hear you
Okay,
clearly.
very good. Thank you so much. It is just a wonderful time for me to share with you. I want to give you a little bit, just kind of background. The Asian American Center is located in Frederick, Maryland, which is about 1 hour from University of Maryland, a little bit over an hour from Washington, D.C. And we are an immigrant, serving agency for about 17 years. This is still very young 501c3 nonprofit organizations. So our targeted population, which is very relevant to this project. Next slide, please. Because as an agency, we serve the immigrant and also the low-income immigrant ethnic minority communities. It's a very relevant to the project that we have today. And I want to personally, again, on behalf of the agency, thank you, Dr. Bao, for including us. We're really looking at some of the vulnerability index that drive us to whom we serve. English less than very well, foreign born other than English, and crowded housing and an uninsured. We are located in the catchment areas in the west side of the city of Frederick that primarily, we have a very high density of low-income immigrants. And as an agency, we do have citizenship and ESL classes, as well as, all the navigation services for health and human services and housing and health insurance enrollment. So it's a very, relevant to us. We're looking at about 15,000 residents throughout our counties. It is a suburban counties in here. About 20% of residents are foreign born, and many of us, and we have actually 60 different languages in our catchment area. And as an agency, we have about 35. Certainly the Spanish-speaking communities are better served than the speakers of other languages. So this is what we like to target with this project. Next slide, please. As you can see that key partners, I just want to again echo to what the first keynote speaker were talking about, the messengers. As an agency, we have 35 languages. We have very, since 2015, we began to develop community health workers. As you can see that these are the folks that come from the communities, know about the communities, and it's just it's very proud to have them. We had meetings. You can see in our pictures that the front row we have, Dr. Taka, Dr. Bowers, and Malcolm. He is with the Healthcare Coalition. The back row we have a field of our community health workers, Chinese, Arabic. I can see Farsi, Thailand, Spanish, and so forth. Of course, English. But these are only a few. We have about 15 community health workers to be, they are lined up for this project. So just very exciting project. The partners, of course, under leadership of Dr. Bauer, from the University of Maryland, Horowitz Centers of Health Literacy. But at the same time, we also have our local communities, the health department, Healthcare Coalition, about 20 some members, such as mental health, division of senior services, United Way, maternal and child health, and so forth. A pretty well represented healthcare coalition in our county health department, our hospital, our federal qualified health centers. I want you to take a look at these pictures and take a look at my, the logo, the Asian American Center, Enhance, Empower, Enrich. We truly, focus on these three strategies because our vision is equities. And before we go further, I just, again, to kind of share with you how important equity is. As Dr. King said, of all the forms of inequality, injustice in health is the most shocking and inhumane. For those of us who have life experience being an immigrant, being refugees, being a displaced workers, so we know what it's like when we have no access to healthcare and how they impact our the health disparity of our countries. So as an agency, equities is our vision, and our mission is to enhance, empower, enrich, to really develop our community with essential skills so that we can be independent and self-sufficient. So we're so delighted to have working with our key partners, from really a multi-sectorial partnership. Next slide, please. So these are the project activities. Again, focus on those three words: enhance, empower, enrich. Training, capacity building for bilingual, bicultural CHW. Again, it took me 50 years, now that to learn more about, the health literacy and system and policy and practices. So it takes a long time for our immigrant communities, to really practice. So it's so wonderful that now we focus on health literacy because we have the language, but we might not necessarily know the health literacy. We can speak English, doesn't mean that we can teach, correct? So that even we speak different languages, Thai, Chinese, and so forth, we need to understand the class standard. And I want to say, we don't take it lightly. It's just so wonderful for our countries, to really have this policy about what are the standards. And also for the CHW who come from the community, understand what are the standards so that they can be, they can really use it and also just put it into practice. So just a good time. So we have evaluation as well, looking at the materials. The materials we're looking at from CDC, perhaps we have, we just start with the Arabic, 85, pieces of materials, and how many of those are, for COVID-19. We want to look at the gap, look at it analytically to see that whether this really makes sense, is it good enough, or how can we improve? How can we translate them even better? So in terms of usable, communicable, information. So we want to use our messengers, CHW. Again, it's being, talked about right now. These are the trusted. These are the members. These are the messengers that people will, will listen to and listen to the concern. Dr. Bauer has shared with us and show us about, to talk about in terms of pregnant women, right? Seniors, adolescents. How can we use this, relay those information relatively and also relevantly, to the population that we serve. So it's just exciting, as you can see, but it's not enough. Just having the trained CHW, getting, understand, health literacy and class standard. We need to work with our organization. So, that University of Maryland, really with that leadership is to do health literacy assessment. Now, I'm in public health for 50 years. I know that oftentimes we say, oh, we don't have enough money. We can't include all the interpreters and translator. No, yes, you can if you make an effort and investment. It doesn't have to be, a full workforce, but you can also invest in communities, agency like us or other agencies that provide you language services, but train those, workers well. So this multi-sectorial partnership is extremely important in terms of health equities, because we have to look at policy, we'll have to look at practices and bring us together. What can we do to make it, to make it usable so that we understand. I will say that health literacy today is COVID-19 material. Tomorrow it will be diabetes. I know that, at least for myself, in our agency, we're very excited at taking part of this project. So these are the project activities. So telling you who we are, what we're doing, why is that? What are the aims? Next slide, please. So, our aim is to really to see that we can continue to have the right message in preferred languages and channels. I know, Frederick, in our Asian community, we have about, down 5%, probably, a little over 12,000 people. Yet, even within, the Asian community have many different languages. We have 11 in this project, maybe more. And we also have from the African continents, we have a few others, and in Spanish. So it's just so exciting. I know that we talked about earlier that it is a community, it's a learning community. We truly are. We learn from each other and we practice, we develop material to increase confidence in the COVID vaccine and testing. We want to see our CHW with long-term, messengers so that they understand the class standards and also health literacy skill. And we also want our organization to look at ways that, yes, we can improve health literacy. We can improve, implement the class standard, with a very, strategic, direction. So with that, I want to thank all of you. Thank you so much. I can't, really describe, how proud we are with all the CHW. I know that they are in the audience right now. We're very proud of you. And so go team. Thank you.
Thank you so much, Elizabeth, for that look at what's going on in Frederick, Maryland. Now I want to turn to another longtime friend and colleague, Susan Bachrach, who is the executive director of the, of the Nebraska Association of Local Health Directors. And she's going to talk to us now about what's going on in Nebraska with their grant project.
Okay, great. Thank you. You can hear me okay?
Yes, we can.
Okay, super. Thanks. I'm very happy to be here today representing the Lincoln Multicultural Health Literacy Project. I'm also excited that I've heard nuggets in both Elizabeth and Dewan's presentation in terms of actions that need to be taken, that I think that we have kind of built into what we're planning to do. So I'm glad to hear we're on the right track. I'm getting to speak on behalf of a great collaborative team that includes my team at the Nebraska Association of Local Health Directors. We are being led by folks at Lincoln Lancaster County Health Department, who were the submitters of this grant. And I will say that they submitted this grant. I actually had impromptu meetings with them about the application while I was in line in the arena to get my COVID vaccine. So it was definitely a heavy lift for them, but there's such a commitment in our city to this work that they found time for it. I'm also here on behalf of the Cultural Centers of Lincoln. They round out our key collaborators, and they are a formal collaboration of several entities in our city, including the Asian Community and Culture Center, Good Neighbor Community Health Center, Good Neighbor Community Center, sorry about that, El Centro Hispano, the Indian Center, Malone Community Center, and the Ponca Tribe of Nebraska. I had to read those so I didn't forget anyone. We are also fortunate to have evaluation support from two faculty with health literacy expertise at North Carolina Agricultural and Technical State University. So on behalf of all of us, thanks for the time to quickly share what we're up to. I wanted to share just quickly some thoughts about how the public health system, I work with the health departments, not just Lincoln Lancaster, but health departments across the state. And when we've had a moment, you know, our first moment came after the first surge, roughly in June, when things had cooled down just a little bit. We were kind of taking a breath, trying to figure out, okay, what's going well, what is not going well, where are we at with this pandemic response? We were asking ourselves, what new ways of working has COVID been showing to us? And I think that probably all of us can think of examples of the way that COVID has kind of the need to react quickly has forced us to look at things differently and maybe move forward with things that we would have been hesitant about. And some of them are really good, and some of them we want to try to hang on to. Other things, not so much, but you know, we have new ways of thinking about food security. We have new ways of thinking about equity. We have new ways of thinking about collaborating with schools and with other partners. So we've been trying to frame regular conversations across our state about what are the things that we want to try to hang on to. But as I was preparing for talking to you all today, I was thinking about that question. And really, I think another question we need to think about is what established ways of working is COVID calling us to really recommit to. And for the folks on our team with this health literacy project, health literacy is what we really need to recommit to. It's been quite some time since our organization has had the resources to really flex and grow our health literacy muscles, and also to lead efforts and help our partners across the public health system to do the same. And so we're really excited to be able to do that. And the reason for this is because as we entered the pandemic as local public health departments, we were on the receiving end of a fire hose of complicated information that was changing practically hourly. And then because we were not prepared enough with the resources we needed, with the right size plans in place, with the right size team ready, with the right relationships, kind of easy relationships, we pretty much ended up just turning that fire hose on the public sometimes. And that is not what we want to be doing. We really couldn't consistently consider health literacy burden. We couldn't, we sometimes were slow at translating materials in the languages we needed them in, to Elizabeth's point. And we just did not have like I said, we didn't have the right messages. We didn't have the right relationships with some of our community members to have the bidirectional, as Dewan was talking about, the bidirectional information sharing, expertise sharing. And to be clear, the pandemic was going to overwhelm even the best constructed public health system. But we can do better, and we will do better because we find ourselves part of this exciting opportunity and investment by the Office of Minority Health. If you want to go ahead and change to the next slide. I think that if I could see people's hands, I was going to ask for a show of hands. If I could see your hands and I asked you to raise your hand if you have ever visited Nebraska, I would say that most of you are probably not going to raise your hand. We are either the last or the second to the last most visited state in the United States, but we are a nice place to visit, and there are a lot of nice people here, so don't let that deter you. But if you had been to Nebraska, you might have noticed that we have more diversity than perhaps you imagine. Lincoln is 80% white, but we have a growing percentage of racial and ethnic minorities, and a large portion of a good portion of our foreign-born residents are resettling refugees. I think one of the most telling statistic for us in terms of where we need to be focusing efforts around language access comes from our schools, where over 12% of the students in Lincoln Public Schools speak a language other than English at home. And of the students that are in the ELL program, where they track the language that is actually spoken, about 142 different languages are represented in our schools. So there's a lot of diversity in Lincoln. And when we think about, and not all of those non-English speakers are newcomers, but when we think about newcomers and we look at where they settle in our state, we see that, or I'm sorry, in our city, we see that they tend to first settle in this corridor of affordable housing in the heart of Lincoln. And not surprisingly, that corridor maps pretty much right on top of our social vulnerability index. So these are areas of our city that have higher poverty rates, poorer access to care, poor access to healthy, affordable foods, poor increased access to risk factors like alcohol and tobacco use. And Lincoln's racial and ethnic minority communities within this corridor experienced disproportionate number of COVID-19 cases, and also had lower vaccination rates, although that particular gap is narrowing. So if you could go ahead and change the slide, please.
So Susan, about 1 or 2 more minutes.
Okay. So, and just quickly, the 3 partners are going to be working in a number of different ways, but Lincoln Lancaster County Health Department is digging into our data to harness their public health expertise and help us know where and how we need to target communications. We have a growing team of bilingual, bicultural health literacy content creators who we are hiring at the Nebraska Association of Local Health Directors. We're getting them trained. We're also leveraging networks like this one to train them, as well as other partners who are part of the project, so that we can really be ready to develop health literate content for a variety of audiences. And then through the culture centers, we're establishing user groups across racial and ethnic communities to help both drive the communication, again, the bi-directional expertise. They're driving what we need to talk about, but they're also helping us develop the communications that the data from the health department is telling us we need to be concentrating on. All of our project partners are committed to or recommitting to best practices for health literate organizations. And to that end, we're going to be going through a process of process improvement through, we call it the Health Literacy Champion process, and Cynthia is familiar with this process. And that's going to establish benchmarks and as well as workable improvement plans for all of our partner organizations, as well as for other entities in our communities. And then we are going to be developing and curating communication resources that will be available not only to local health departments and to the partners in this project, but to other partners throughout the public health system. And the last slide. I think the outcomes that we're moving to are really very similar to what everyone is looking for. We're looking for increasing those vaccine rates. We're looking for decreased COVID-19 infections and better communication around all the things that go around encouraging people to do those things and to stay healthy. But our real golden ticket with this project is increased system capacity to really have a team of culturally and linguistically diverse communicators who are ready to respond to changing communication needs in the public health system. We were hit with a fire hose of information, and through this project, we're hoping that we're going to establish the kind of system in our city, and that's going to benefit our whole state. That when the next time we're being hit by a fire hose, we are going to be better prepared to turn around with a garden hose, and we can direct information where it's needed, when it's needed, at a flow and a pace that our audience can handle, so that they can take the actions that they need to take to stay healthy. And that's it.
Great, thank you so much, Susan. And in the chat, I put that we have been hosting those champion materials for your organization. I don't know if you're going to be putting them out, but right now people can access them through the Horowitz Center as a way to see what Susan was talking about there with that specific approach. So our final speaker is another longtime good friend and colleague, Marianne Abrams, who is at the Ohio State University College of Medicine and Nationwide Children's Hospital. And she's going to talk to us about what's going on in her part of Ohio. So Marianne.
Thank you, Cynthia. And I'm so glad that I'm able to be here this morning to share our plans and experience with you. It's been so wonderful to hear the opening presentation by Dewan, and then to listen to both Elizabeth and Susan as they describe their projects, and to hear the themes that are clearly running through these, and then see how those are interpreted in our respective communities and populations. So I'll take you through our project. We were excited to have the opportunity to apply for this when it was first announced early last spring. And we really reached out to, because of the funding process, we reached out to our colleagues and partners in public health, and all of us were excited about the opportunity to be able to use this funding to really address obviously a critically important need, and to again build into that longevity component while we're speaking about health equity. And that was what was translated into the title of our project, Building a Health Literate Community Toward an Equitable Response to COVID. Next slide. I'm really fortunate, we are really fortunate to be working with great colleagues and team members. I'd love to have a lot more names up here, but we're working in Franklin County Public Health was the applying agency through the Board of Commissioners, and Alex Jones is a great leader there. I'm representing Nationwide Children's Hospital, and then Gavin French and Makita Porter are the leads for Columbus Public Health. Franklin County is in the center of Ohio, where Columbus, our state capital, is. The population overall of Franklin County is about 1.4 million, 1.3 million. Columbus is about 850,000. So we have an interesting relationship in that Columbus Public Health has responsibility primarily for Columbus and Worthington, one of the other cities, and then Franklin County does the rest of the community, the county, but everyone works very seamlessly and collaboratively, so that's wonderful. And I have to say, I'm just in awe of the work that they're doing and their esprit de corps. And I don't think I've ever seen them without a smile on their face, although I know that they are challenged and exhausted and yet right back at it every moment. Our external evaluator is Tatine Santel at the University of Hawaii, and her tremendous team. And she is a health literacy expert and has a lot of experience working with underserved and minority populations. So one of the things that really struck us about this opportunity was also that emphasis on organizational health literacy, which came out in the application request, as well as something that was really important to all of us. And we also viewed this as a great opportunity to build a great response to COVID, but also to build something hopefully that will sustain and carry over to future activities. Next slide, please. So I'm going to summarize our project by walking you through some of these key components. Cynthia mentioned those in the beginning. We were asked to develop a disparity impact statement to really help us focus on the purpose of the grant and to help us think through how we would go about our work. So our primary goal is reducing COVID-related health disparities in Franklin County and to improve the health outcomes among racial and ethnic minorities through the process of this grant. And our population of focus is the racial and ethnic minorities who reside in the 90 census tracts where we have the highest social vulnerability index. These are populations similar to what both Susan and Elizabeth described as at risk for a variety of social determinants of health reasons, as well as healthcare access issues and COVID disparities. So the racial and ethnic minorities, including African-American, Black, Hispanic, comprise about 30% of the Franklin County population. And we also chose to have an extra focus on a smaller population, but a highly vulnerable population of new Americans. So Columbus is home to many East African and other refugee and immigrant populations, including Somali, Nepali, Bhutanese, and Eritrean and others. So we are reaching out and collaborating with two of those in particular, Somali and Ethiopian, and by working with others in that community, we will be identifying additional new American populations and partnering with leaders from that community. Next slide. One of the important very underpinnings of our work is our partner advisory committee. And we're very fortunate to be able to build a specific advisory committee for this project, but by initially tapping two already extant groups, one that was convened by Franklin County Public Health, who had an equity advisory committee in place for many years, and Columbus Public Health had a health literacy committee. So between these two groups, we were able to talk about and attend their meetings in the spring when we were developing our proposal, and to get their input, ideas, agreement that this was an important thing to work on, and also to just learn and be so impressed with the tremendous work that was already underway. So we've got that advisory committee is being built out with new partners as well. And we want to work with them to get their ideas, their suggestions, to be a sounding board, feedback, and also to promote it among others that they work with, and to be participants so that they can also play an important role in our work. Next slide, please. And then to kind of carry out this and to build on that work underway, we have two main goals. The first is, as I said, there was great work in messaging and communication already underway. So what did we want? We wanted to bring the added value of health literacy to that. So rather than saying we're going to do a lot of new things, we want to create this array of community and health literacy informed messaging and modalities, especially for the racial and ethnic minorities, but also some that are already in place. Next tab, please. So we want to use those to address misinformation, vaccine hesitancy, by building the communication, the folks already doing this communication work to help build their health literacy skills, to increase their cultural and linguistic competence, and digital health media practices. And one of the other partners on this project, the Ethiopian Tawahedo social service situation, is going to be leading us and helping with the cultural and linguistic components of this work. Next.
So Marianne, like another minute or two.
Okay, I think I can do it too.
Okay.
So we want to build the capacity of those individuals and spread that. We want to be able to assess the improved accessibility, acceptability, readability, and actionability of the materials that result from that. Next tab. Increase their knowledge and skills. Next tab. And go ahead. And the evaluation will look at those materials, the participants, but also the populations reached, and ultimately our COVID-related data. Next slide, please. And then our second goal really deals with that organizational health literacy and capacity building for the community. You can pause there. We have the benefit of having these great partners, and we want to pull them together to develop a sustainable community-wide infrastructure of diverse organizations, the obvious healthcare delivery folks, and then other entities that touch health in many ways. So we'll be developing ongoing training and activities. We're going to develop champions and training teams within those partners, develop a variety of training and educational opportunities so that they will have capacity to sustain that work once this grant is complete, and lots of different options and ways they can be involved. Next section. And then we'll be evaluating that by looking at those participants' knowledge, attitudes, and skills, and assessing organizational health literacy to see if we can embed that and build that sustainable health literate organizational capacity for whatever the future holds for other health conditions and whatever comes down the road beyond June of 2023. So thank you for allowing me to share my story, and I look forward to the next part of our session.
Great, thank you so much to our 3 speakers. So this session ends at noon, which gives us about 15 minutes for Q&A and discussion. I saw that there was one question that had come into the Q&A for Dawan. So Dawan, this is for you. It was a question from Deborah Stein and said, how do we discover the credible messengers in our communities? Is there a way to approach folks with respect while making partnering with us attractive? So Dawan, any thoughts about that? Discovering the credible messengers already in communities, and then what's a respectful approach and what's really in it for them?
No problem. This may sound cliche, but meeting people where they are. Oftentimes, credible messengers are operating in their authentic selves. So whether it is Troy Staten, who's a barber and a barbershop owner, he's just naturally just cutting hair. However, he's credible. Whether it's a coach inside of the community, a credible messenger could simply be someone who is a store clerk, that has strong relationships inside of the community. So I would say some of the best approaches to build relationships and pathways to credible messages is volunteer, meeting people where they are, go inside their space, and take a genuine interest in their work, their interests, things that they're doing, stuff like that. So volunteer and asking questions, listening, and see how you can support them. That's one of the easiest ways that I could recommend. And lastly, knowing that each human is different, so you can't have the same type of approach to everyone. But if you look to see the humanity in anyone, you can have the authentic way to engage someone. And the second part of that question was
anyway, respectful, like how to be respectful and how to show what's in it for them, like why it would be beneficial to even like take our calls or have a chat with us.
Yeah, that's going to start from active listening, because oftentimes when we engage people, we make the assumption of why this may be beneficial to them. However, once you have that conversation, that dialogue, exchange, you will learn that what you presume to be beneficial is maybe something that's too far in the near term and not right now. So you got to find what is relevant to the person's need at that moment. And that comes from exploring conversations and asking those questions.
Thank you so much. You got a shout out in the chat that this was wonderful advice. So thank you for that. I did see a question come into the chat. We'd like you to use the Q&A for your questions and discussion, but in the chat, someone asked, Karen Brown said, could the panelists explain more about their digital media practices and what methods are you going to use related to digital media? So if any of our panelists, or Dawan, if you have any advice on social media or digital media practices. Any of our panelists want to take that?
Cynthia.
Okay, Elizabeth, why don't you go first?
Okay, well, certainly WhatsApp and WeChat are very popular, and we find that it's very convenient to our community. And first and foremost, identifies, those groups that and again through your, the community's members. So, which group is that? So it's a neighborhood, it's a civic organization. It's just tremendous, connections you can build using those, platforms. So we do that, quite often.
And in addition to building on social media, one of the dimensions that we wanted to fold into the work underway is best practices, if you will, toward how people find and use the web for information. So getting input and understanding of just core accessibility issues, how navigation works, how people manage getting health information from the screen versus something written or another alternative, especially those with limited literacy or limited health literacy or perhaps other languages and cultures. So we are going to invite our colleagues at Communicate Health, who are our good partners here with IHA and others, to help inform that as well.
And if I could add something real quickly about digital media practices, you should know that the way social media algorithms work is based on exposure. So how often you are sharing content, who you're sharing it with. So one of the best practices I would recommend is cross-pollination. Tagging and leveraging some of the sister organizations, some of your influencers to share your content so you can reach a broader network. Other than that, you'll wind up finding yourself talking to the same people internally and never reaching a broader audience, because if they're not inside your network, they're less likely to see your content. So also I would recommend, I just recommend cross-pollination, collaboration of content sharing.
Thank you. All good advice. Elizabeth, did you want to elaborate on that? You have your hand up.
Not on this point, but what was asked earlier in terms of how can we make the community attractive to work with us. Workforce development. I would like to share with these conferences that we actually start our CHW training way back in 2015-16, and then the pandemic comes along and give us more resources. So look into your department of workforce development at the state, the DLLR, department, or the Chamber of Commerce, or the Pell Grant, or higher education. So really, jobs is so important to invest in our, indigenous communities, if you will. That giving them the opportunity, because they are the resources, they have tremendous assets to help us to improve health equity. So I would again promote the ideas about developing the future's community health workers, and they will come. I know that I have such a great time seeing my team is growing every day. Well, not every day, but then with this project that they're learning and they are also giving back, and it's just a great feeling. Thank you.
Great. We have a question from Thomas Coyle about what challenges are presented by the ongoing new knowledge related to COVID-19 and messaging. So, we got the image of this fire hose, right? That we've all been just really doused with this fire hose, and COVID was changing not just, week by week or day by day, but hour by hour. So what are the health literacy challenges by all of this new knowledge related to COVID, and how does that have to change how we think about messaging?
I'll start out with that one, Cynthia.
Go ahead.
I think that you've described the challenges, the fire hose, and I think that health literacy, when we've been thinking about best practices for health literacy, they tend to be methodical. There's checking back, there's teaching back, there's user testing, there's multiple iterations, there's a lot of process that ideally goes into kind of developing your messaging and testing your messaging and deciding how you're going to put your messaging out. And we did not have that luxury. And so I think that is a challenge, and it'll be interesting to see and learn from the other grantees in this project to sort of see who figures out the most effective ways to crack that nut, because I think that for us has been one of the biggest issues. It has completely, generally public health moves very slowly, for better or for worse. These are long-term outcomes that we're trying to move, and the influencers and a lot of the things that we're most concerned about in public health tend to be, they're systemic things that are not changing from week to week or month to month, or unfortunately year to year. But it does make it easier to predict messaging that you're going to need and take the time to sort of hone it. But we did not have it for COVID.
Okay. Anyone else want to add to that?
It's an interesting question, and I think one of our key messages in the future, one of our first key messages when we're confronted with something like this again, or whether it's not even quite that large of an issue, is this concept that the information is going to change, and that's normal. And because I think those, us who live in academia or public health with recommendations and evolving, changing knowledge, take that for granted. And I think one thing we've learned is that a lot of people struggle with that. And people want answers, and then they think they have an answer, and then suddenly it's different and changing. And we sort of say that, well, we have new data, we have new recommendations. And so, okay, so now we know the right answer. And then if that repeats over and over, I think that can really undermine acceptance and trust. So maybe being a little bit more explicit upfront and throughout. We think we're saying it, but I think maybe we need to think carefully about how to say that in really, really plain language, that everything is going to be changing. We're giving you the best information we have right now. And we will give you the important changes too. I just think that could be part of what has resulted in some of the hesitancy and the frustration that people experience.
Right, we got a comment too about conflicting information, and I've commented on that for years in the nutrition space, because people have thrown up their hands a lot of times when it comes to nutrition information, because they see it as constantly changing, that you can't really rely on what anybody, the experts, say about nutrition information, so we're just going to do what we want to do. So I think we have some prior examples of what happens when the public feels like those experts don't know what they're talking about, they keep changing their mind, it all conflicts anyway, so be gone with them, right? So
Yeah, I agree. It's just the speed at which the changing of minds occurred was much faster.
Exactly. Okay. Any other comments on that? We do have one more question that's come in, but I don't want to cut off the discussion. Were there any more comments then about what COVID has taught us about messaging? Okay. Then another question we got from Mercedes was to add to social media, if you're tagging organizations, they should, especially professional societies, they should also help like-minded organizations in getting awareness out. So I think that raises an interesting question of solidarity. Like, how have you all experienced that already, or you all talked about your partnerships that you're now building through these grant mechanisms, and Doan talked about like his partnership with the University of Maryland, Baltimore, and other organizations in Baltimore. Do you all feel like the pandemic maybe did a couple of things, like both surfaced maybe some of the weaknesses or absences of partnerships, but maybe also created and strengthened partnerships? Or what do you think, is there going to be some newfound solidarity, do you think, coming out of this? Or sort of what's your take on what we all owe each other now?
I'll jump in. I would
Okay.
say that from where we sit in our experience, it has definitely developed new partnerships and strengthened ones that were there, both for the local health departments as well as for us as a statewide association. And I think gives us avenues for thinking about communication differently. I can think, for example, with the Restaurant Association, that was not an association that typically we worked a lot with, but that's a new partner that has a lot of both interesting access and unique access to the public, and also both as workers and as customers. And so that's just one example that's popping into mind for us.
We have a couple of minutes before we wrap up this session. Any final thoughts from our panelists, including Doan? Anybody want to offer a final thought? Elizabeth? You know,
Well,
one
so-
sentence takeaway for us?
I think it's just empowerment. I can not think of anything, but just the community of workers themselves are so empowered to this through this project. And I think they really set, for us in the future, they are the one that, in my biased opinion, really will be making a lot more contribution to improve, health equities. So that's the message I would like to share.
Mary Ann, any final last words?
I just want to reiterate, this can be a very big kind of large project to get your arms around. I feel like I continue to learn every day from the direct colleagues that we have through the grant itself, but all the other partners that we already are kind of working with via the Equity Advisory Committee and the Health Literacy Committee, and the new ones to come. My eyes are continuously opened, and I think if we're always open to what that next insight it will enrich this work and make it so much better and stronger.
Susan, a final thought?
I don't really have anything to add.
Okay, all right, no
I'm
problem.
final thoughtless, but I'm excited about this work. I'm excited about all these partnerships, and I just think we are going to learn a ton. Actually, I will add, I think that this is huge that we have a federal level investment at this level in this particular topic. We have been scrounging for peanuts trying to get things off the ground, and I can't imagine that we're going to be anything but successful in proving the value of this kind of investment.
Exactly.
That's a
So
great one.
Dewan, you get the last word here.
Great. I would leave with if COVID haven't taught us anything else, it taught us that be relevant is to be efficient. We saw COVID reporting interventions change weekly, daily, or sometimes hourly. So the tools in which you have used yesterday may no longer be efficient today. So make sure that what you're providing people is relevant to the needs of the moment.
Very good advice. Thank you so much. And I want to join me in thanking our panelists for a tremendous kickoff session. So this wraps up our opening plenary, talking about this new federal investment, as Susan said, an historic investment in health literacy. So thank you very much for joining us for this session. And please come back in 15 minutes, take a stretch break, grab some lunch or breakfast or whatever time zone you're in, refresh yourself, and come back for our 12:15 session. You can choose from one on information accessibility or on civic literacy. Again, you have a choice for our 12:15 time slot, and we will see you in our next session. Thank you so much.
Thank you, everyone.
Thank you.